now we're going to move into the talk with me and Al about ultrasound and rupture for AAA, right? Not just AAA, but rupture for AAA. So how many people, I assume everyone's using ultrasound to diagnose a AAA. How many of you are using it to diagnose the rupture of that AAA? Cool. All right.
Thank
so,
you. No, I'm Samuel. Thank you.
Mic drop, let's go.
I'm surprised Chris Fox doesn't have one with like the entire medical school diagnosing ruptured AAAs at like 20 hospitals and up on the top of the mountain. Maybe next year. I don't know. So I have some disclosures. I do some consulting for Philips. Bristol Myers Squibb pays my hospital, which I see none of for research, but it goes under my name. So let's talk about why we want to talk about AAAs, right? So there's a lot of AAA out there, right? We're all getting older. Some of us have had to get progressives now. So we're all getting older, so we're all at risk for AAA. Our patients are getting older. And you start getting risk of rupture once you start getting about 5, 5.9, and greater than 6, and that starts going up. More incidence of AAA in males, but greater incidence of rupture in females. And then you start monitoring them, and then you start seeing that when it starts getting larger or you get accelerated growth, that's when you're going to have increased risk of rupture. Caveat being that some of those prospective registries were mainly Caucasian males. So those numbers may be different if we start expanding that out. So diagnosis of AAA, pretty easy, right? It's part of our ultrasound guidelines. It's in the imaging compendium. It's part of the core training for residency, part of the core training for fellowship, right? And even ACR agrees with us, right? AAA diagnosis and monitoring, top of the list, ultrasound duplex, no radiation, usually appropriate, scores very high on appropriateness guidelines. So once we find a AAA, now we have to talk a little bit about whether that AAA has some instability versus leaking versus rupture. And then we all go to CTA, right? So that's our gold standard, that's what we're doing. And then what are we actually looking for on CTA? We're looking for that contrast to extravasate into the mural thrombus. So your AAA has a little bit of mural thrombus where a little clot forms or there's stagnant flow. And then do you see the CT contrast, if you can get it now, dissecting into that? Do you see retroperitoneal hematoma, right? A little easier on CT, that's one of the things we're looking for. We're looking for wall breakage, meaning you have a hole in the AAA, right? Yeah, my AAA is ruptured because there's a hole in it. Or draping, this sort of deformity of the AAAs, it starts to kind of expand and ooze over your vertebral body. And then the crescent sign where you have acute blood in the mural thrombus. So this is not actually contrast, this is actually the non-contrast image where you have hyperintense acute blood within there. Just like you have blood in the brain, right? Same thing. Gets a little harder when you have contrast, but same thing. And that's what they're looking for on CT. So that's what your radiologists are looking for when you order that CTA, when your patient finally gets there, if there actually is any contrast left at your hospital, and then you can actually get the studies. But what about if we go with ultrasound, right? We can diagnose the presence of AAA. Can we actually diagnose rupture? And yeah, we probably can, right? So many of you have probably heard of this article. You've seen some of it, right? And we're categorizing ultrasound findings and reports of 3 new signs. So they came up with a total of 8 signs, 5 old, 3 new, and they gave a whole list of different things. So if you're doing AAA scanning, are you going to be looking for all 8 things? That gets a little iffy. And we can talk about when they looked at this, in 388 patients, they have pretty good sensitivity, specificity, but pretty bad sensitivity. But that's sort of the thing, right? Positive predictive value, you have the thing, great. You have a big hemorrhage, you have a ruptured AAA, I'm finding the clear cases. I'm not necessarily going to rule it out on everybody and be like, yeah, you're probably fine. Here's some scalaxin and you can go home. Probably not going to work out so well, right? But trying to remember all these things and looking for all these things becomes a little difficult. So what I want to go over today is a little bit of the way to think of this. So some of those things, para-aortic hypoechoic area. That's blood around your aorta, right? Retroperitoneal hematoma, hemoperitoneum. We're all good at hemoperitoneum, right? But basically, all 3 of those are just hemorrhage. We're looking for signs of hemorrhage, either free fluid, retroperitoneal, or periaortic, right? Retroperitoneal, remember, kind of difficult to see. You're going to find displacement of your solid organs, and you're going to have to track it down. It's going to be a little hard. Your periaortic area, or fluid, you're going to look around the aorta for areas of fluid, such as that, where you have a little bit of fluid extravasating out from the aorta, right? And hemoperitoneum, I don't need to show you an example of that. So basically, are there signs of bleeding and blood outside the aorta? Yeah. So that sort of simplifies this for you, right? The other thing is your AAA deformed, or is the wall open? we can probably combine those together where there's deformity of the AAA and it's starting to have a wall break, right? Like you have a AAA like that. Well, I think we'd all agree that that's pretty deformed and doesn't look right, right? Definitely abnormal. And then as we're scanning through, we can see more deformity, right? Your AAA is no longer sort of round or ovoid. It's now sort of U-shaped as it's just sort of oozing around that vertebral body. And then we can look at other ones where we're scanning through and we can see the AAA. And then we see that the wall isn't quite continuous. And then when you freeze it, there's like a hole there and blood on the wrong side along with hematoma. And then you can have other ones where there's like a little nipple where it just kind of squirts out. And that person did not have a good day, right? So now we're sort of taking those 8 signs and we're condensing them down. What about the luminal thrombus interruption or floating thrombus layer? You basically have a break in that mural thrombus. It's broken, right? Whether there's a fracture or there's a fracture with a little piece floating over, you can see here in this image, we have the AAA where that thrombus and the endothelial layer that's formed over time is now fractured. They're thin enough, you can even do it with a linear. And you can scan, you can see where that thrombus has fractures and breaks in it. And then you can see what's called that floating layer where there's a fracture and there's a little piece floating there, and you can even see that slight line cracking through it. And then the other one, the luminal thrombus inhomogeneity. If you can say that 5 times fast, you win. That's just layering in your mural thrombus, right? So you're looking at that mural thrombus and you're looking for layering. If that doesn't make sense or you're not sure what to look, think of your Jell-O dessert, right? You have your different layers. Basically what's happening is you're having bleeding into that mural thrombus and you have layers of old thrombus, new thrombus, and fresh blood. So basically you have Jell-O dessert in your aorta, right? That's the image the author showed. And then you can see here in this sample, we have a little bit more clear layering, right? You can clearly see that there's different layers of thrombus and different age of thrombus versus fresh blood in that aorta. And you can see another example here when I freeze that clip for a still, and you can see that layering effect there. And you can see it also in this patient. So now we've taken that 8 signs of rupture and just condensed it, right? Do you see deformity or breaks in the wall? Do you see layering in the thrombus, breaking of the thrombus, or hemorrhage? I think we can all look for those 4 things. But it's a little hard to remember them in order. So if we sort of go back in the other direction and think about it as a spectrum, right? First, you're going to see fractures in your thrombus because there's a break in the thrombus. Then as you bleed into it, you start getting those layers of different levels of blood, right? New blood, old blood, fresh thrombus. And then your aorta deforms, and then you see the wall break. And then, unfortunately, you have free fluid, retroperitoneal, or periaortic fluid. So if you're looking for just these 4 things as sort of somewhere on that spectrum, you're going to be able to just not diagnose that there is a AAA, but sort of that it's an unstable, leaking, or a ruptured AAA. And once again, getting your surgeons, getting your teams involved sooner, and getting that ball rolling, because now you may be able to get that person to CT much quicker in order to stratify how you're going to repair it and what you're going to do. You may not obviate the need for a CT, but you can condense that timeline, right? And we have all the studies that we've done in pelvic, gallbladder, all kinds of things, where point-of-care ultrasound condenses that time frame. And we can think of it as that stage imaging. And in the future, perhaps there'll be things like the same group that found those signs also did contrast-enhanced sonography, where they're looking for ultrasound contrast in the aorta and looking for areas where extravasate. And this was sort of a case series, but you can see that in these areas, he's seeing mostly thrombotic contrast leakage, right? Leakage either out of the aorta or into the thrombus, the mural thrombus. Right? And then we can also have the ones where we have post-repair, where we have our endoleaks. And we're seeing those patients where we have the AAA still, because we still have that aneurysm sac, and we're seeing unstable clot that's just flapping around outside of the graft, or even endoleak, where we have our type 2 endoleaks or type 3 endoleaks, and we're putting color, and we can see where the actual fracture is and where the actual leak is. So why do we want to do POCUS for AAA rupture? It's because you're looking for the things on the spectrum, right? Mural thrombus, layering, wall break, deformities, and then frank hemorrhage. And other people have done it, right? A lot of case reports, but there's a bunch of case reports that come up, and we've diagnosed it in different areas, not just the Italians in their case series. And then just recently published, right? The review of lawsuits related to point-of-care and ultrasound applications. Mike did it a while ago. This was just redone. It's in preprint now. But what they found was that non-performance of ultrasound seems to convey the greatest medical legal risk. Not the error in diagnosis or the use of it, but lack of using it seem to be more attributable in those cases. Now, there might be a little more risk in some of the advanced applications, which this will fall into, but not using it seems to be your biggest risk. And if there's any questions, you can always get a hold of me. And I will turn this over to Al. Who probably has more data on this.